Hi, everyone, and welcome to the Otolaryngologic Clinics podcast. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the October 2021 issue dedicated to the dizzy patient, guest edited by Drs. Maya Swartchik and Meredith Adams. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. Today I'm speaking with the guest editors of the October 2021 issue of Clinics on the dizzy patient, Dr. Maya Swartchik and Dr. Meredith Adams. They are both MDs and they both hold masters in science, and they have designed this issue with science and compassion in mind. Dr. Swartchik is associate professor in the Department of Otolaryngology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in the Northwell Health System in New Hyde Park on Long Island in New York. Dr. Adams is associate professor in the Department of Otolaryngology Head and Neck Surgery at the University of Minnesota in Minneapolis, Minnesota, which was the home of Prince, and where we went dancing once upon a time. So welcome, Maya and Meredith. I'm so happy that you're here today.
Great to be here.
Yeah, thank you for having us.
So you've put together 17 articles that comprehensively cover this subject. I personally love having the hardcover issues on my shelf so I can pick up and I can read a bit from time to time. And if I have something particularly challenging case, I can do that. But I will point out that 3 of your articles also have online video content that is accessible with either the physical or the online subscription or purchase. And that's available at www.oto.theclinics.com, which is where our listeners can find all of our issues and articles and all of our podcasts. And of course, you can find all our podcasts, which are one per issue, wherever you get your podcasts as well. So, Maya and Meredith, let's get started. You know, when a person comes in and they say, "Doctor, I'm dizzy," that can be a frustrating opening line from a patient, but it can also be a very rewarding patient-physician interface with a really rewarding outcome. So I'm going to start with Maya. What do you find most frustrating when you evaluate patients with dizziness?
So I thought about this, Sujana, and the thing that I find frustrating is not the patient themselves, but sort of how they have been shuffled around. Usually that's the thing that bothers me the most. So kind of like in pediatrics where you like the kids but you don't like their parents, it's like I like the patients but I don't like their doctors. And so what I mean by that is I don't necessarily agree with the referral patterns that happen in my sort of neck of the woods. I feel like there's overdiagnosing, such as diagnosing BPPV without an actual exam, underdiagnosing, specifically I think vestibular migraine seems to fall in this spectrum. I also feel like there's too many radiologic studies and not many useful radiologic studies. There's usually incomplete workup, and sometimes people don't even look at the basics like orthostasis or a metabolic panel. So that's what I'm frustrated about. So, Jana, did you ask me about the rewarding stuff as well, or we're going to leave the rewards?
Well, let me ask Meredith what she finds frustrating in these scenarios.
That answer totally resonates with me. I think we have patients coming in who are clearly suffering. It's a vulnerable population. They need help. And they come to us sometimes looking as if, you know, we're the end of the road, we're the savior, which is a really difficult position to be in. And then you add like the stress of worrying about missing something that may be very serious, the worry about the impact, and you look back on your care and you can see there's just been this explosion of testing. There's been this just vortex that this person has gotten caught in. And you just wonder, like, man, what if we'd met this person early on? Could we have just taken a good history and gotten to the bottom of this? Could we help them? But the storm oftentimes has erupted by the time they get there. It can be hard to sort through that sometimes and can be frustrating.
I have to tell you, so I'm I'm in heaven right now with two other neurotologists and me, right? Like I'm just in my happy place right now. I will tell you that one of the additional frustrations for me when I see these patients is they have often not been taken seriously. Like if they don't have a quote unquote easy problem, they have been shuttled. They've been told that they're crazy. They've been told they're depressed. They've been told that they're anxious. They've been told they don't like their spouse. Usually it's women who've been told they don't like their husband or their kids. And I'm like, you're kind of allowed not to like your husband or kids, but you also shouldn't be dizzy, right? So I think what we are describing is a big emotional onlay from this, as you so rightly described, a merry-go-round that they've been on with sort of never-ending testing and random diagnoses that don't get anywhere. So what's rewarding? And we'll start with Maya.
I think it's always that response from the patient. It sounds a little cheesy, but we're physicians, and I think we all know why we're in this profession. But when you have someone who you feel like you've helped, but one of the favorite comments from patients to me is when they say, you actually listened. I also really like being able to give patient a different perspective and how to look at their disease. And in fact, my favorite appointment is the one that's the least favored by my billers, but it's the one where I don't prescribe anything, I don't refer or don't test. The only intervention is really just a counseling. And so I find that the most rewarding, like feeling like I've really contributed just by talking, which is kind of funny because I'm a surgeon, but I think I'm surprised by how rewarding that is.
And Meredith, what about for you?
A large part of caring for people with vestibular disorders is just like walking alongside them, like in their suffering. And I think there's a great joy and honor in serving, just showing love to other people in that way. Even when we can't get to the bottom of it, which is always really exciting when you get the answer, you figure it out, you have this intervention. Even when we can't, there's this opportunity to offer hope and maybe just change a mindset and help people see positively a way forward through that.
Let's move forward from our gestalt and let's talk about, we're not going to talk about each of the articles you guys have in this issue, but we're going to talk about the big general concepts that are covered and covered really beautifully in your issue of clinics. When you see these patients, we are, as you said, lots of data to review, sometimes lots of myths that the patient has been led to believe that need to be debunked, right? A lot of things that have to happen. So what is the optimal triage and clinic flow for these patients? Like, how do you shepherd patients through that difficult process of diagnosis? And I might say, in other words, what's your dream team of specialists involved when you evaluate dizzy patients?
So Jana, I think for me, like I said, that's the most frustrating part. But then when you really sort of break it down into the processes of how could we make this better? And I've been tasked to try and make that better, and I thought about this problem a lot. And so you can approach it in a couple great ways. There's a really nice flowchart in this chapter, which basically gives you 3 sort of common ways or suggested ways in which you can run a practice. And I really like that aspect of this chapter. For example, you can start, the new dizzy patient can start with a hearing test and vestibular testing first before they refer to the otologist. That typically does not happen in my practice, but it's possible to do that because you could possibly weed out or select out some patients that don't necessarily need to be seen by a physician. Another way to do this sort of a triaging would be to start with the dizzy patient who then sees the otologist first. This is what typically happens in my practice. However, a lot of times I do feel like I am seeing a lot of patients, whereas neurology is seeing very few patients, and I think that could definitely be split, and the workload can be split. There's another idea to have some sort of a screener, either a health professional or someone with some basic training that can screen these patients and then refer them out better. And there may even be some artificial intelligence or computer programs that could maybe do that for a patient so that you would know sort of where to take them. One of the main parts in this algorithm is BPPV. This is the simple thing that could be easily diagnosed, easily fixed, does not need any other studies. and possibly sort of decant some of that volume from the physician. So that would be one thing to sort of really consider. When it comes to the list of specialists, you have to consider your microenvironment. If you had sort of you can just put together your dream team. Always have a good neurologist, that's for sure. Cardiologist, I'm sure Meredith and you, Sujana, can tell me about millions of times you've seen patients who actually end up having some sort of a cardiac issue, whether it's they had a coronary artery disease or orthostasis or hypertension issue. But in any event, a good cardiologist would be great to diagnose and to treat these kinds of patients who don't have non-vestibular dizziness. Other things to consider, definitely a physical therapist who does both evaluation and treatment, an audiologist who not only does hearing tests, but can also do some vestibular tests and more sophisticated tests such as rotary chair testing. A psychiatrist would be great. I have a hard time to get them to buy in, but a psychiatrist would be a wonderful addition to patients because anxiety is comorbid a lot in these patients and can certainly potentiate their dizziness, and the other way around, their dizziness can potentiate anxiety, and also other psychiatric disorders, panic disorders like agoraphobia, depression. In any event, a good psychiatrist would be great to have on the team. And there's other sort of adjunctive clinics, such as a memory clinic that will do a neurocognitive assessment and a traumatic brain injury clinic that can do a comprehensive evaluation. And I would love to have a nutritionist, especially for my patients with Meniere's disease and a vestibular migraine, where nutrition and diet changes can certainly play a big role. So that's sort of the comprehensive list to me.
I really like that. The article we're discussing is the one written by Weinreich, Martin, and Agarwal, and it's called Overview of Dizziness in Practice. And one of the limitations that we find in the American healthcare system is that when somebody comes to an institution, particularly if they have governmental health insurance, they can really only see one type of healthcare provider on that same day. So the comprehensive approach where you might see them all together is harder in most insurance environments in the United States. However, at the Veterans Administration Hospital, everything's a bit different. So what we did for our vestibular disorders evaluation clinic up at the Bronx VA hospital was we were able to streamline from 6 to 8 visits per person down to 3, because we actually do a combined assessment, and particularly important in the veterans who either have PTSD or traumatic brain injury, they didn't have to keep on telling their story over and over again, to me one day, to the vestibular therapist the next day, to the audiologist the next day. So the team we have in place there is myself, the vestibular therapist, and the vestibular audiologist all talk to the patient at once. So the history ends up being really robust, and then we can determine what testing, if any, needs to be done, and then that's their second visit is for whatever testing, and the third visit they get, quote unquote, their toolbox of what we think is going on and what we'd like to do in terms of treatment, and we can involve the other specialists that you talked about as needed. What that does is it makes the history robust. It doesn't stress the patient out. And again, as we talked about, they've been to so many doctors, whether they're in the civilian world or the military world, and being taken seriously by somebody who knows what history to get is really very important. So, Meredith, when we care for these patients and their families, it's really all about maximizing quality of life. So what are some of the comorbidities that can affect quality of life in dizzy patients?
There are so many different causes of dizziness, but as you're saying, something fairly consistent across the cases are these impacts that the dizziness is having on quality of life. We invited Dr. Risk and Liu to write a really nice article on interviewing and counseling dizzy patients with focus on quality of life. And they have done an excellent job highlighting a few main factors, but also giving clinicians some follow-up points, essential questions to ask, like ways to elicit this. I want to highlight a few of them. In particular, I think we need to think about the impact dizziness has on our involvement in work life and our social life. I mean, one great stat in here is that a quarter of people change jobs, or 1/5 actually give up work as a result of their dizziness, and half of people with dizziness are missing work on a regular basis for their symptoms. This is a huge source of distress, and it also has many ramifications for family life and for activities of daily living. And we need to be sure that we ask people, what do you do for work? How is this impacting these daily activities? Some people are on FMLA, some people are on disability. This or need it or don't, and that is going to influence probably their response to our treatment recommendations. How motivated are they to take that next step? And I think some people also may be candidates for vocational rehab, and we need to make that available to more people. It takes like taking that next step and asking and then doing that. And I think another disability or impact we often see, of course, are these psychiatric comorbidities. I mean, who hasn't just observed this? I mean, we see that anxiety and depression are 3 times. Like, there's 3 times the risk of having that in a group with dizziness than the general population. And we know it makes these symptoms worse, and we need to ask about it. I think I often find myself having this conversation with patients about, okay, you have the dizziness. Maybe I do or do not know what caused it, but it leads to anxiety. And then there's this cycle. The anxiety makes the dizziness worse, and the dizziness makes the anxiety worse, and we get trapped. And you've got to do something to break that cycle. And sometimes it's really going after the anxiety or the depression first with behavioral health, getting health psychology involved, getting psychiatry involved, or different counseling methods. So these are things we can do to really impact quality of life, even if we don't know for sure what the cause is, or it's a place we can meet someone right then when we're first getting to know them. They bring up a couple other things, just cognitive functioning. We hear this difficulty with multitasking. Many patients with dizziness experience. And then sleep disturbance is getting more and more attention among dizzy patients. Whether obstructive sleep apnea itself is actually leading to more dizziness, oxygen deprivation, or changes in the brain, or if the dizziness is somehow related to it otherwise, it can only make things worse if you don't have enough energy kind of going into that next day.
Yeah, I think, the more I read the articles in all the clinics, and the more I think about it, the more sleep affects everything that we do. So disjointed sleep, poor sleep does not allow for recovery. And I think you're right. Until we've had that dialogue with patients, often nobody's talked to them about that. Yeah, okay, you only sleep 3 hours a night. Oh, that's fine. No, that's never fine, right? So I appreciate that. Maya, we're talking about getting an efficient history and physical exam, right? So that we can get to the counseling part, but figuring out what's wrong with them or what we think might be going on. So in a busy, dizzy practice, how long does it take you to perform a basic history, basic exam? What do you do? How focused is your history? And then how frequently after your H&P or your history and physical exam do you feel like you pretty much know the diagnosis?
Oh, I know when I walk in. Just kidding. To me, I feel that if I'm rushing, but I want to make sure I don't miss anything, I can do an exam probably in about 2.5 to 3 minutes. And I'll talk about the components of that exam. And I'll also compare, pretty much I do the same as what the chapter recommends. I don't do orthostatic testing myself. The other part is the history, and I think I can probably really focus and really think about the diagnoses that are working diagnoses. Probably within about 4 or 5 minutes, I have an idea of where we're going. This is not to say all patients, but I can certainly say a great majority. This is sort of where that is. And I think at the end of that whole history and exam, and also some comorbid factors and past medical history, taking everything into account, I usually say about 80% of the time I narrow it down to 1, possibly 2 diagnoses. And the other 20% of the time, it's a little bit of a broader differential, 3 or 4, or sometimes really just stumped. And then that's where I usually require some further testing or a trial treatment period. I really want to point out this chapter that we're talking about, the efficient dizziness exam. written by Dr. Rausch and his collaborators. If you have anyone in your practice, such as residents or someone you're trying to train, this is the chapter to give them. It really sort of summarizes all of the working diagnoses, the most common diagnoses. So table 1 gives you the 8 most common or 7 most common diagnoses, exactly what you're sort of looking for and what the associated symptoms are. And if you give them this tool, they too can do a history in a pretty brief amount of time. Same thing, figure 1 sort of gives you an algorithm of questions to ask to get to the diagnosis. And if you follow this algorithm and you sort of focus your patients to the question and make sure that they answer the question that you're asking them, you can get there. That's where the art comes, right? That's the art of medicine. It's not asking the questions, but understanding sort of the context of that patient's mindset, what their sort of level of understanding of what they are, how frustrated they are, and trying to sort of look through all of that other stuff, their emotions, to try and really figure out what the symptoms are. And I have no problems with making sure that I focus them, and I will say, I need to focus you. We need to really assess this. This is important to me. So I feel like if you can do that with a patient, you can move pretty quickly through the exam.
Do you separate when you ask them the questions or finish your sort of general ENT exam from when you do the vestibular exam? Like, Joel Goebel talks about the 10-minute exam of the dizzy patient, and there's, 14 parameters that he looks at, and it's really excellent. It's not in this issue, but it's a excellent resource for people. Do you do everything sort of in the same room? Do you set aside a different time to do it?
I do everything in the same room. My chair goes all the way down, so I always perform a Dix-Hall pipe on patients, so that way I can do that. And in the same room, I have them. I don't have a foam, but I just have them sort of do a rapid alternating movement, such as for a Fukuda test. I have a microscope in the room, but you can also use an otoscope. So I do everything there. I do a head impulse test. I do the basic eye movement tests. And as far as sort of balance and gait, like I said, a Romberg and a quick Fukuda test. A lot of the stuff will manifest if patients have any sort of a pathology that will manifest in some of those tests. And if it doesn't, then you do have to go through vestibular testing if you're suspecting a vestibular cause. It's important to note that, for example, a head impulse test, that you're actually able to diagnose only when there's a big difference between the two ears, like visually, for visual inspection, not with goggles. So you can do a head impulse test, and it has to be about an 80% difference between the two ears for you to be able to notice that difference. So if a patient has a 60% weakness or 60% difference, you're going to have to get a test to really test it. You may not elicit that on the head impulse test. So I think knowing that and knowing the limitations of this very focused exam, I think you can get through it pretty easily. And I'm not sure, I have not found much need to go through more sophisticated, such as Frenzel lenses or goggles or foam tests or anything like that.
So that's an excellent way to segue into the next article I'd like to ask you about, and that's, I'm going to give this question to Meredith. So, Dr. Adams, you wrote an article with Zuniga on the efficient use of vestibular testing, and I love the emphasis in this issue of clinics on efficiency and essentially patient-centric evaluation and management. So we've discussed that not every dizzy patient needs every or sometimes even any testing. So how do you decide when to get vestibular tests for dizzy patients? When do you find that they're the most helpful, and when are they not?
I think there have been some great studies looking at how far you can get without tests, and that is what has informed my approach. Looking at questionnaire-based studies, just asking people about their symptoms of peripheral versus central hearing loss, a little bit about their medical history. You can predict the diagnosis about 80% of the time. And that tells me that almost 80% of the time I probably don't need tests to take that next step. But I keep it simple. I decide based on something we probably learned in medical school. When you're going to get a test, ask yourself, what question am I asking? What question do I need to know the answer to? And I need to know the answer if it's going to change my diagnosis, if it's going to change the treatment that I'm going to offer the patient, if it's going to change the outcome, not because I want to plumb the depths of the vestibular system, just like nerd out on vestibular physiology, but because I need to know it. And so I always start, what question am I asking? Do I need to know the answer? And then which of the tests is going to give me the answer to that? And so in this chapter, we tried to make this vestibular testing like for the rest of us, like for me, it's getting really accessible, and try to say, what questions are these tests good at answering? What are they not good at answering? And so I feel they don't give you the diagnosis, right? You can't ask yourself, does this person have Meniere's disease, and get an answer from a test, but you can find out how their vestibular system's working. So we're going to learn about the physiology. You can't look at this and tell how symptomatic they are, how disabled they are by testing. That's not what you're going to find out. But what you can ask, and so what I do use them for, is when I need to figure out the site of the lesion. Is this coming from the peripheral system or the central? Because I'm not sure. Am I seeing, right versus left, activity? Is it the utricle? What organ system do I have? We can use them to tell the severity of a lesion or the extent. So I think as Maya was mentioning, are we seeing an 80% weakness, or is this something more mild? And we can use the tests for looking at the frequency affected. So caloric's very low frequency testing, like I can see a deficit there. Rotary chair, we're getting more physiologic, might not see a deficit. Or you look at VHIT, now we're in like very physiologic testing. So we have we can get a whole smattering of like a vestibulogram now, right? Like all the different frequencies being tested to see where the lesion is.
And by VHIT, you mean vestibular head impulse?
Yes.
I'm sorry.
Yes, video head impulse test. So we're taking that head impulse test that Maya's mentioning, and we're putting basically high-speed video camera with a gyroscope on the person and getting to do this in an objective manner now. So we're actually seeing the catch-up saccade that can be difficult to detect with the naked eye, and we're measuring the gain. How is that eye catching up with the head when we're moving it? We can use these tests also to see how compensated someone is after a loss. I think I probably use it for that as much as anything. Person's had a crisis event, and I want to see if I'm probably suspecting that they have a vestibular weakness, but I want to see if they've compensated or recovered, and therefore should I go on to get vestibular therapy, for example. We try to give people some different ways of thinking this through, in addition to a number of diagrams we put in just to emphasize the physiology and what each type of test looks like and its test output. At the end, we have a table that kind of walks people through some different clinical scenarios and just defines questions. So you have an acute vestibular syndrome, we'll talk about, and you're asking, is it a unilateral lesion? Is it compensated? We've tried to point people to what tests to get and the findings, how you might interpret that. So if you had a caloric asymmetry and you still had nystagmus, for example, you might start to think that it's an uncompensated lesion, for example. And we tried to walk through a few times when you probably don't need it. So I mentioned that profound diagnostic uncertainty. This is not the time. If you don't know what the person has, you are as likely as not, in my opinion, to get some results that now you have to chase down, and you could just kick yourself because there's some positional nystagmus that you don't even know what to do with, and you're asking yourself, is it time for neurology, or maybe it would have been nice to just not know that and just, keep digging down the historical piece. But we're hoping we can help clinicians make decisions based on that, about that table in our rubric.
I love the figures. I love the table. I love the way it helps people formulate the question. As you said, until you ask the right question, you're not really going to get an answer that you can use. So Maya, we've talked to the patient, we've examined the patient, now we've done some testing. What about neuroimaging? You guys put in an article by Malak, Hagiwara, and Wen on neuroimaging of dizziness and vertigo. So what are the appropriate radiologic tests, and when is neuroimaging useful in these patients?
Yeah, so I think in practice, what ends up happening is patients have usually had some sort of an image by the time they see me, and unfortunately, it's usually the wrong test. For example, the one that's most commonly misused is a straight-up CAT scan of the head when patients present dizzy to the emergency room, which would be ruling out large strokes, which if patient had that, they would have other symptoms, like a big hemorrhagic stroke or something. The other one that's commonly sort of not used is in acute vestibular system, where a patient truly has vertigo and they don't have a positive Dix-Hallpike or it's not BPPV by history, they do not get an MRI, and they should. So these are sort of some common pitfalls, but this chapter is, I think, very nice in the way that it lays out pictures of all the different CAT scan and MRI abnormalities, some of them more rare than others. It's interesting because when I looked at this chapter, you have to sort of know what your patient is diagnosed with. So either peripheral or central cause that is suspected, to then sort of put in an algorithm of what imaging to use. I think it's probably more useful for radiologists themselves. The thing that's interesting is that a lot of the central causes of dizziness that I see are patients who have a vestibular migraine or PPPD or triple PD, which are central disorders, and those actually will have normal imaging. On the radiologic point of view, imaging that has findings that are central will be the more rare ones. So, for example, vestibular schwannoma or Chiari malformations or vestibular basilar insufficiency. But in any event, I think the chapter is very nicely organized in those two categories, peripheral and then central causes that do have findings on imaging, and that's the one thing to keep in mind. So if you wanted to sort of have the golden summary of what that would mean, basically you would get a CAT scan for canal dehiscence, otosclerosis, cholesteatoma, and perilimb fistula, and basically get MRI for everything else. The only difference would be for any specific vascular studies, such as vertebrobasilar insufficiency, you would get a CT angio or an MRA. But essentially, just remember that a CT is not very useful unless it's a very specific diagnosis, and those you would usually be able to tell by an audiogram. Radiologic imaging is great to use if you know what question you're asking, sort of like what Meredith was saying with vestibular testing. But unfortunately, because of these referral patterns, sometimes it's not the way that it's used. So if we want to practice good medicine, I would look at this chapter.
I think one of the other pearls is when you are ordering a test, don't just write dizziness. Help out your brother and sister in neuroimaging, right? Say, dizziness, dizziness, unilateral hearing loss on the right, suspect whatever, or, suspect superior canal dehiscence, suspect, migraine, suspect something, so that you're helping them clue in as to something that could help you formulate your treatment plan.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America, and today I'm speaking with Drs. Maya Shrechik and Meredith E. Adams, the guest editors of the October 2021 issue called The Dizzy Patient. You can find all issues of the clinics in your institutional or personal library, I hope. And all issues, articles, and podcasts are available online at www.oto.theclinics.com. Let's talk about some specific complaints that patients might present with. Positional vertigo, as you said, Maya, is very common, especially as we age. When the patient says, I get dizzy when I look up, today somebody said, I get dizzy every time I look up to take a picture of a tall building. And I'm like, why are you walking around taking pictures of tall buildings? So what's your differential? And then we did talk about when you do a Dix-Hallpike. So when do you do a canalith repositioning procedure?
Yes, I do want to say, when Meredith and I talked about sort of how to organize this book, one of the things we discussed was, how do we help the clinician? Like, I want to be able to have a practice, and like you, Sujana, have this book in my office and just pull up a chapter if I'm seeing a patient, and that will be a helpful chapter. And one thing that I found in sort of classically organized textbooks was we all talk about BPPV, which is dizziness, more specifically with turning to one side or, in that dependent position in a Dix-Hallpike maneuver. But I get a lot of patients with I get dizzy when I look up, and it's hard to find that in a textbook. And so I thought, this would be a great time to use clinics because it's a wonderful resource for updated clinically relevant problems, I thought this would be a great time to do this because I encounter this in practice a lot, yet I don't really know that there's a great resource that will sort of summarize it for me. But having said that, BPPV, or benign paroxysmal positional vertigo, is certainly one of those disorders that's in this differential. There are other disorders that are in this differential. There are some posterior fossa lesions that can cause this as well, which would be sort of a central positional vertigo. Cervical vertigo, which is, for some people, still hotly debated. For other people, they sort of accept it as a diagnosis, but are not sure how to diagnose it or treat it. But that's certainly the one that I feel like is important to look at because people don't talk about it a lot, or at least there's not much literature on it. But it certainly exists, and I can name several patients that have had this disorder and that was successfully treated, and it usually can be treated with physical therapy. Other causes of peripheral disorders, vestibular-basilar insufficiency, and then triple PD, and phobia and anxiety. So just to illustrate that, some people develop more of a fear or a phobia of performing a maneuver, looking up. And sometimes just that can sort of set them off into a more of a panic attack or an anxious kind of spin. And I'm not saying that's all patients, it's a minority of patients, but it's another thing to sort of look into the differential when it comes to these positional episodes. Positional vertigo can also be a part of healing vestibular neuritis or labyrinthitis, and it can also be a part of vestibular migraine. So it's not a very specific symptom, and you have to sort of inquire about the rest of it to really get the clues. But like I said, I think this chapter, as many of them do, highlights things that are difficult to pinpoint in a textbook, but are very clinically relevant.
So let's say you find, classic posterior semicircular canal, BPPV, rotary nystagmus, fatigue, latency, the whole shebang. Are you doing the canalith repositioning in your office? When do you send them to PT? What do you think about the people who have found like somersaults and all sorts of stuff on the internet, often coming in because now they feel sicker? But what do you think about that?
So great question. I actually do the repositioning in the office. Every time I put someone in Dix-Hallpike position, which is every dizzy patient, especially every new dizzy patient, I'm prepared for them to have nystagmus, especially if they had a correct history, meaning if I see it, I'm going to reposition them right there and then. Sometimes if I'm in a rush, it's not the best scenario, but if I see it, I sort of committed myself to help that patient, and so I will. I sort of have a limit. I'll do I think the most I'll do is 3. And if I still see spinning, I'll set him up with a vestibular therapist. If I'm really in a rush, I'll do 2 repositionings. If they're still have the nystagmus in a dependent position, then again, I'll send them to the vestibular therapist. So the answer is yes. I do them, and I do 2 and even 3 sometimes maneuvers in a row. Even after I've done them and completed them and think that the crystals have been repositioned successfully, I still give patients a referral for a vestibular therapist in case they need one or in case this happens again, just for time-saving purposes. I usually also tell them that it's easier for the vestibular therapist to do so, and they have sort of better beds and set up for that, especially for patients with low mobility issues or overweight patients. And as far as the home exercises, I tell everyone to do the Brandt-Daroff exercises, which is the repositioning maneuvers that a patient can do themselves. I think it's hard to perform an Epley maneuver for patients, and sometimes they have seen things online. But typically what, at least in my population, goes is that they'll say, I tried this, and I got so dizzy I stopped. So I usually tell them to have a friend or someone supervise them that they trust, because it's important to keep going, right? All these maneuvers, if someone gets dizzy, you stay in that position, and then you keep sort of moving. So I think it's always easier to have it done with someone. They don't have to be a health professional, but just someone who's going to sort of perform be a calming force and a hand holder.
So, Meredith, I want to ask you, because Maya and I are both in pretty urban practice settings. And of course, Minneapolis is a very urban city, but you have a lot of rural population. Like your catchment area includes a lot of rural practice. So I wonder what you do with these patients who maybe you repositioned in the office, who live really far, distances in the Great Midwest are really big.
So I think with this in mind, our health system actually has an amazing network of vestibular therapists and contacts throughout greater Minnesota and surrounding states. And we have prioritized as a group having therapists closer to where people live precisely for what you are describing. So I think I'm incredibly blessed to have that resource to point my patients to. And we offer to connect with their therapists at outlying sites to walk them through this. And have also worked on some telemedicine aspects of this. And so there's a point at which sometimes you can diagnose this or at least help work through some of the maneuvers at home with patients. Not ideal, but it's doable if someone is a distance out.
Very nice. It's interesting, right? As a lot of weird stuff happened during the pandemic, but I think all of us being able to recognize some of the utility of telemedicine and the utility of distance, being able to reach our patients was very helpful. So Meredith, let's talk about, we have already mentioned when people go to the emergency room because they're dizzy. So many, if not almost all of our patients with acute vertigo, so spinning vertigo that feels like they are just tumbling and tumbling, often accompanied with nausea and vomiting, sometimes accompanied with diarrhea, sometimes accompanied with sweating, and almost always with some degree of panic, right? Every single patient who's had spinning vertigo can tell you exactly the circumstance of that first event of their vertigo. So they will often go to the ER, right? Obviously this sounds like this is the end. So it is very frightening for the patient. It can be actually very frightening for the healthcare provider. They often have like really scary looking nystagmus, and they are either vomiting or having other, diaphoretic. They look terrible. And then there's a fear of missing a stroke. And Maya did mention it when she talks about the neuroimaging, sort of the knee-jerk reaction of imaging. So what are some of the tools that we can put into practice as ear, nose, and throat doctors, as otologists, as neurotologists, and teach our emergency department and other consulting colleagues to help evaluate patients who present with acute vestibular syndrome or, quote, vestibular crisis, end quote?
This crisis event or acute vestibular syndrome is very frightening, right? And it does stimulate so much healthcare utilization, but just also fear. And I think many of us try to start with education. We need to engage with our ER peers and even ourselves to know how we can make a difference here. Patients, oftentimes, even just starting and figuring out, is this acute vestibular syndrome versus an episodic vestibular syndrome is going to help. With the acute vestibular syndrome, these people have all the symptoms you've described. It's usually the first time event. It's one time and it's lasting 24 hours or more. So it just keeps going. And episodes, obviously episodic is the stereotypical thing coming back, more like a Meniere's disease. But you don't always know that the first time, as you pointed out. When the person comes in, they may still be in the throes of it. If it is, acute vestibular syndrome, we as otolaryngologists think, okay, vestibular neuritis, right? That's going to be the most common cause 60% of the time. If they have hearing loss, labyrinthitis, we go to that. And we need to remember other things. There's concussion, there's ototoxins, there's drugs that can contribute it. Something we should keep in top of mind, which I think the ER always has top of mind, is that many of these people actually do have posterior fossa strokes. It's actually estimated to be 25% of people who come to the ER with acute vestibular syndrome, which is higher than I think about it in my head, because I'm always trying to kind of think, hey guys, think peripheral, But truly, we need to catch these. Many of them are still missed, and the people have quite a bit of morbidity as a result of missing these strokes. In the first chapter of our book, actually, in the Weinrich and Agarwal, they have this fabulous table. It's called 10 Pitfalls and Pearls in the Diagnosis of Stroke and Acute Dizziness and Vertigo. And one of the really common misconceptions include things like, if it's true vertigo, it must be your ear. No, it could definitely be a stroke. And if it's worse with head motion, how many times have we heard that? Wow, it's worse with head motion. It's got to be the ear. No, that's a stroke too. And auditory symptoms don't necessarily mean that it's going to be peripheral, right? An ICA infarct is going to get your labyrinth. And so just because you have hearing loss does not mean that the person does not have a stroke. That's teaching us, frankly. I think some of the otolaryngologists need to keep that in mind, as well as the ED. But then back to this issue of imaging, I think we need to remember the CT, which is Sometimes it's just a reflex. Sometimes it's because people have to meet JCAHO requirements, right? We have these direct to ER metrics of like who goes directly from the ambulance to the ER and gets a stroke workup. That's part of their quality metric for stroke. People get CTs without an exam, but only 16% of the time, are they finding something. So the sensitivity is very low, and a negative CT doesn't rule this out. And MRI is what we need, but even that can miss a stroke if it's small, less than a centimeter, especially in that first 48 hours. I love this chapter that we've talked about with us, acute vestibular syndrome. They've really highlighted a great tool that I think all of us should learn and at least teach our ER colleagues, and that's the idea of the HINTS exam. We don't get to do it as much in the clinic as otolaryngologists, but called to the ER. And so it's a great mnemonic. It's a way of doing an exam to the patient after you've done your history. You've done your timing. You got the timing. Is it spontaneous? How long is it going on? What are the triggers? But then you do the HINTS exam. So HINTS stands for head impulse, nystagmus, and testis skew. You can take an acutely vertiginous patient and do a head impulse exam. They don't like it, but you can do it. We've talked about that head impulse. They're focusing on a target, usually your nose. You're having them fixate on it. And by rapid head turns, you're seeing if they have catch-up saccades. Like, can that eye catch up with the head as you turn? And if it can't and you have a saccade, that's suggestive of a peripheral lesion, usually suggestive of a problem with the ear. Whereas central problems often spare the vestibulo-ocular reflex, or they spare that, usually won't have a catch-up saccade. And then look at their nystagmus. We've all learned about the different types of nystagmus. If it's peripheral coming from the ear, it's usually horizontal. It's in one direction. It suppresses with fixation. Strokes can cause, or other central things can cause vertical nystagmus, torsional nystagmus, direction-changing nystagmus, for example. And then there's the test of skew. That's the old cover-uncover test. We're looking to see if there's an ocular misalignment. This runs through our otoliths, but you cover one eye and then cover the other eye. And the lower eye, if you have one eye lower than the other one, it's going to raise up as you flip your hand, and that tells you that there is a skew deviation. That's a sign of a central lesion, usually on the side of that lower eye. So if you count up your HINTS exam and you see something suggesting a stroke, that would be normal hit, normal head impulse test, vertical or direction changing nystagmus in the presence of skew, or any of those are positive, frankly, you should move on to the stroke evaluation. HINTS plus is that you ask them about their hearing loss, and that's just for the sense of an ICA stroke could cause some hearing loss. You have central signs and hearing loss, still go for the stroke eval. But kind of interestingly, this outperforms an MRI in that early time frame. It's a sensitivity of 95%. I think we should all be familiar with it, and we should be able to teach people how to do it.
So that's something very interesting that I think we need to start practicing, especially looking for skew deviation, because until you look at a lot of normals, right? Until you kiss a lot of frogs, you don't find the prince, right? So I think it's really important that we train ourselves as to normal and normal variants in these tests that we're otherwise not familiar with. The article that you're talking about was written by Barron, Steenerson, and Agliano, and it's called Acute Vestibular Syndrome and ER Presentations of Dizziness. We talk about that first vertigo episode ends you up in the ER. But patients who have recurrent vertigo, my goodness, the last place they want to be is in the ER. They're so afraid, and you talked about this earlier with quality of life, they're so afraid that one of their episodes is going to happen at work and someone's going to call the ambulance, right? And it's really interesting. I think it's, when I talk to them, because they know that nothing will happen to them other than like a stroke workup, which they're not having a stroke because they're just having their recurrent vertigo. So what it is a big hullabaloo. When they finally get back to work, all the how are you feeling? How are you doing? Oh, I heard this. Oh, I heard that. Right? So it's really, when you talk about quality of life and missing work, having to somehow exit work with as much grace as possible when you're having a vertiginous episode is very difficult to do. Wouldn't you say?
Yes. And we need to help prepare people for that. I mean, people need to have a safety valve, whether that's, their Phenergan or their Ativan in their pocket or something like that. I think we have a responsibility to always leave the encounter with, okay, let's make a plan. How are you going to manage this next episode? If it's positional, you're going to call PT or call me, and we're going to reposition it. If it's spontaneous, what vestibular suppressant has worked for you, and And don't take it every day as a preventive. It's only for these episodes.
Mm-hmm. And I hope our listeners are getting this. Like when we empower our patients to understand not only what's going on, but that they can control it and not become helpless, we actually prevent that panic response. We prevent the escalation of the emotional response to what's going on. Let's talk about, we've talked about a lot of tough stuff. Let's talk about kids. Oh my goodness, the dizzy child. So, when I was a young lass and I was an early assistant professor at New Jersey Medical School, I wrote an article in Spanish. You would be very proud of me, Meredith, called El Niño con Mareos. And I wrote it with Richard Konigsberger, who was an outstanding pediatric neurologist. And a lot of times, children who present with dizziness or vertigo, mareos, in childhood actually become migraineurs in adulthood. So it's often a very first sign of what will develop into either a typical or atypical migraine pattern. But it is really hard to parse out what's happening to the child with dizziness. It's hard when they're a younger child. I actually think it's harder still when they are a teenager or a young adult, and there may be some other forces at play. There's a really good article by Kelly, Janke, and Patterson called The Dizzy Child. And I wonder if you can talk to us about how do we approach these children? How do we approach their parents? How do we make it so we're not sending them down a rabbit hole of like random testing and, treatments?
The way we go about determining dizziness causes in some ways, is very similar, but other ways needs to be modified. I mean, we still need to ask, tell me about these symptoms that you're having. But keeping in mind, of course, that the children, depending on their age or other things at play, they may not have the language yet or the words to really express what they are experiencing. And so we often are going through their caregiver to understand this. But we should still ask. I mean, I think we probably all had the experience where the caregiver is describing exactly what they're seeing happening, but you can look at the child and ask, and they just, the story is different. But it may be very, I had a child with a really good description of Meniere's disease lately, and I thought, wow. I mean, no, Mom, my hearing goes down. I can't hear. And there's a roar. It's like, roar. The kid's doing this. I'm like, wow. And it's an invisible disorder. So there's only so much the caretaker can do, and they're probably pretty overwhelmed, seeing their child go through this during that time. Something that also comes out, and I think they highlight this in the article, though, is we can also look at the functional effects. We get a history, but then functional effects can be different in children. One thing, and I love this, they have a table of like motor milestones. I mean, sometimes we may see like a delay in reaching motor milestones as an indicator of a vestibular deficit. You've probably seen all of us have a child stand on one foot, and at what point can you stand for certain periods of time? That being delayed might show that there's something being impacted. But we also need to ask about visual acuity. I mean, kids may be having a hard time seeing, a hard time moving their head and keeping things straight if there's a vestibular deficit. And there also might be a lot of psychological distress that manifests differently in children than in adults. The testing is feasible. I mean, you can test children, but you really should think to yourself, again, like, what question am I asking? Is this really getting to the bottom of it? And keep in mind some modifications may need to be made. Video head impulse test is a quick test, and it's something that children can definitely do and tolerate well if you're looking for a large deficit. And VEMPs can be done in kids. Again, it's not nausea provoking, and it's the pads can be put on easily, but a caloric can be a bit much, for some kids to go through that feeling. It's a bit much for a lot of adults, but I mean for a kid that might not know what's going on. I think really the key that comes out of this is just remembering children can get that whole range of adult disorders, but the differential really needs to include other things, and migraine is really at the top of that list, as you said. I mean, benign torticollis of infancy often is migraine phenomenon. And we're seeing as Baronese Society and some of the groups get together, kind of reclassification of that, that benign vertigo of childhood that often gets confused for BPPV, but it's BVV. Now we're calling that, basically it's just like vestibular migraine in kids.
Can we talk a bit about teenagers? I think they are the most challenging, boys and girls. So it's not just the monthly hormonal changes maybe that the girls are having. There's just so much going on at the same time. And I find that once they've lost significant days at school, there's a illness category that they sort of put themselves in, their parents have put them in. There's my child used to be, every single teenager with dizziness used to be a straight A honor student on their way to becoming a valedictorian, which is kind of awesome to me. But, so you've got this multifactorial thing that's, I must say that it can be the most challenging for me, because there's so many emotions at play in that room that are affecting everything. Do you have a secret for me, Meredith?
I wish I did. I've seen the challenge with, let's say we're sure it's migraine, just identifying the triggers and then talking about things that we need to avoid can be an incredibly difficult conversation with a parent and the teenager. Sometimes even when both people in the room have migraine, I mean, we both know that this is running in the family. We should have full buy-in. But maybe we're not ready to stop kind of with the food triggers. We're not ready to give up video games late at night, giving ourselves simulator sickness, which is happening. And I have seen that sick role. And I think it is an issue of there's motivational interviewing. They're trying to bring the whole family along, saying we're all improving quality of life together. But if everyone's not bought in, it can be very, very challenging. And I think there's a lot of counseling involved and often trying to load the boat again, like getting some other practitioners helping us out with this. I think there's both health psychology, if people are open, neurology helping us. That's a time definitely to get more help with the migraine.
So, let's segue to migraine. So, and again, I think this is a very challenging, we're sort of in like the very difficult phase of this podcast. The sort of very difficult meaning not that the patients are difficult, but the problems are challenging and the approach to them is challenging. You have a really nice article by Zaleski, King, and Munfarid looking at vestibular migraine and its comorbidities. It's hard to make the diagnosis. I was happy to see that there is, in fact, a table included that includes sort of a beta of the International Classification of Headache Disorders, 3rd edition, that actually has criteria for vestibular migraine. Because for a long time, neurotologists were these weird stepchildren in the neurology community where we were like, no, we're sure it's migraine. And they were like, it is not, 3 from column A and 2 from column B, so it can't be migraine. So how are you making the diagnosis? When do you involve a neurologist in the process or with a child, a pediatric neurologist? How do you start with let's talk about diagnosis.
And I don't know if that day is completely past of the neurologist kind of questioning this. At least I think we still have that experience sometimes. But no, I think these criteria have helped us a lot. I mean, getting something in writing certainly lends credence to this. I think the key is we need to move past the days right now where like everything can be migraine. I think we've all thought, oh, there's a little bit of dizziness, a little bit of headache, oh, migraine. I think we're doing the patient a disservice and probably our field a disservice for now as we get on the outskirts of diagnosis. But if we look at these criteria, I mean, I think some of the keys are first, people are having vestibular symptoms, right? I mean, that's part of it, of moderate to severe intensity, but there can be this huge range of how long it lasts, 5 minutes to 72 hours, kind of taking it outside of the shorter Meniere's criteria with that. People do need to have a history of migraine. Like they truly have to have been diagnosed with migraine at some point. So knowing those criteria is important, like the type of headache that's associated with that or visual aura, and just the disability that goes with it. And then with our vestibular symptoms, we are having at least half the time an additional migraine symptom. So that's a headache, unilateral pulsating, or a headache that's worse with physical activity, photophobia, visual aura with that. So for me, I'm wanting to hear that there's been migraine previously. If this is the first time they're having dizziness, I look for family history. I get into some of these other comorbidities that go with it, but have really been trying to stick with this to feel most confident. And I always start with like preventive therapies in terms of just trigger identification, just talking through the whole thing. I have handouts I give people about different things that we eat, other inputs into our bodies, thinking about stressors to the body, sleep regulation, and hormone changes. Commonly seen women coming in kind of that menopausal time frame where this becomes a new thing for them, and we talk that out, different strategies there. And then I am open to starting migraine prevention regimen, but I will say we just have tremendous just partnership in neurology here, and there's a great neurology nurse practitioner I like to work with too, and who often partners in the care of these patients, given that, frankly, I think they have outstanding expertise in many of the medication adjustments that need to occur. But that's how my practice has evolved over time. I used to be much more involved in the medication prescribing, and then realized that I just think she does it better, frankly. Mm-hmm.
So it's interesting, right? Once you talk to them, I think about the diet and the possible triggers. I had a patient come in last week, and she's like, I realized that grapefruit is one of my triggers. And I'm like, I'm sad for you, but I'm glad for you, because you don't have to have grapefruits, and then you don't have to have, your vestibular migraine. So Maya, we talked about the international classification and sort of making sure that we are staying scientific as we treat these patients. What's your take on how you approach these migraineurs?
Migraineurs, yes. To me, the main thing is triggers, right? So, and it's having patients understand what it is that, what kinds of things can trigger them. So anywhere from physiologic factors, such as hormonal changes, to barometric pressure changes, to changes in sleep patterns, and then these factors such as dietary input and dietary triggers. So that's one of the things that I really do discuss with them. And just taking some of that extra time really gives me a way to treat them. And I'd say about 80% of patients, I start with this sort of conservative management of trigger identification and avoidance. I get at least a favorable response in the first sort of 6 weeks of observation. I also start a magnesium supplement. I don't know if we discussed that, but certainly that's another low-level sort of management where it's easy to obtain, easy to take, usually not much side effects, but can have effects on the migraine and then vestibular migraine symptoms as well. So my take on it is trigger identification and avoidance if possible.
So I don't have the amazing right at my fingertips neurology resource that Meredith has. What do you do, Maya, about starting them on meds?
Yeah, so, I found there's a migraine patient handout that's been useful that's written by John Carey and Tex Shadow, and it's basically a good handout to give to patients, but it also is good for physicians because at the end of that it sort of summarizes some of the agents. And in the chapter here, those agents are sort of classified into their pharmacological groups. For me, I have a good amount of female patients and a good amount of female patients who are weight conscious and who are not excited to start amitriptyline or nortriptyline. And for those patients, Topamax has been or topiramate has been one of the medications that I've used. Also Effexor, which is a combination serotonergic and norepinephrine reuptake inhibitor, seems to work better than the straight up SSRIs, which are better for triple PD diagnoses, for example. So I am not reluctant to start any of these medications. When it comes to the calcium channel blockers and beta blockers, I just feel like a neurologist is better with these types of medications. So if that's where I'm going, then I'll enlist them. But for me, would be the top three is Topamax, Effexor, and nortriptyline for a select group of patients.
Thank you. I'm Sujana Chandrasekhar. I'm consulting editor of Otolaryngologic Clinics of North America, and today I am having a really fabulous time talking about The Dizzy Patient, which is the October 2021 issue of Clinics, with the guest editors of that issue, Dr. Maya Shrekich and Dr. Meredith E. Adams. And you can find all the issues of the clinics as well as the articles as well as the podcasts at www.oto.theclinics.com. So Maya, let's stick with you for a second. Let's talk about this article by Jiam et al., which was non-vestibular dizziness, and by Bay, which is the neuropsychology of dizziness and related disorders. You guys reached beyond the typical, quote, otolaryngologic disorders to include these non-vestibular and neuropsych contributions. So can you give us a couple of key take-homes from this?
Yes, I think the neuropsych chapter is written really well, but it's also sort of talks about the comorbidity. I think, Sujana, at the beginning of this podcast, you sort of alluded to the fact that a patient is entitled to be anxious and also have a vestibular disorder, but it's also telling you that there is a higher than the general population incidence of psychiatric disorders among people with dizziness. And the other thing to think about is that stimulating the vestibular system actually causes sort of a stress response. And so it's like one thing potentiates the other, and it's important for patients to understand that. It's important for patients to understand that when they leave your office, you're not telling them you're crazy. You're telling them you may be crazy, but you also have another disorder going on, and sort of to understand how these psychiatric disorders interplay. The other thing that's sort of interesting in this chapter is the sort of the cognitive impairment that patients with vertigo and dizziness have. It's sort of I explain it to patients and to myself that it's almost like their brain is working in double time when they're trying to overcome a vestibular dysfunction or loss. So that they usually feel exhausted just by simple sort of daily movements. And it's one thing to explain sometimes this cognitive impairment and tiredness that they have. And sometimes I've included these kinds of effects in disability paperwork, but also it gives patients sort of a break. Sometimes they're a little too hard on themselves when it comes to understanding their symptoms. When it comes to the chapter on non-vestibular causes of dizziness, there's really great charts in this one as well. It really tells you about syndromes that we don't think about much. One that I feel like I didn't know much about is the autonomic dizziness, but I certainly have patients that sort of fall into that category. There's a great figure 2, that talks a little bit about sort of the different kinds of dizziness that can happen. So again, beyond the vestibular dizziness, so endocrine, cardiovascular, oculomotor, those kinds of things to consider. There's a couple tests that one can do to check for these disorders. Again, sometimes for me it feels like I'm overwhelmed, but I think with the specific headings in the chapter and a couple simple charts, I think we can sort of start sifting through these non-vestibular causes. It's not often that a neurologist has to deal with them, but sometimes if you're trying to refer a patient to specific specialists that would be able to help them the most, it's good to at least have the general system in mind. And for me, the autonomic one is the big one.
Yeah, I think it was interesting. There's some accompanying video content here, and there's a nice flow chart on medication-induced dizziness. You know, that's another problem. We see polypharmacy, especially as people are getting older. So it's a lot of really interesting information in both of these articles that really, I'm hoping will make me a better doctor now that I have read them. So, Meredith, you know, we talked about vestibular therapy. We talked about the fact that you do have some outreach for people who can't make it all the way into the medical center, which is terrific. You guys put in an article by Carinder, Greslak, and Telian that looks at vestibular therapy and falls risk assessment. So can you give us a couple of pointers on this one?
Yes, I think many of us are familiar with physical therapy for BPPV and how that can be beneficial. And we wanted to also include an article that talked about vestibular therapy from the other side of things and really introduced this to clinicians who may not understand the principles behind vestibular therapy and what actually happens when you send your patient to vestibular therapy and how can you expect it to help them. I think this is really a standout article, and I want to point everyone to the just amazing video that is linked in here so you can see the exercises in action and actually teach your patients from them. But the group here has really shown that this is an evidence-based approach that includes patient education, talking to people about managing their triggers, minimizing vestibular suppressants, and lifestyle modification. And then
let's just say that one more time.
Yes.
Minimizing vestibular suppressants. Let's just say that together.
Yeah. Oh, let's say that. Let's say it 1,000 times, right? I mean, yes, thank you. I mean, talk about something that impacts quality of life with this prolonged use of vestibular suppressants. Please stop. That should just be the answer often. And with that, once you get them off the vestibular suppressants, you have a chance of vestibular therapy being effective for people. They need to be off. They talk about 4 main types of exercises they go through with people. Usually it's a home exercise regimen after a little bit of supervised work, periodically. Many of us are gaze stabilization exercises. We're working on vestibulo-ocular reflex, having someone turn their head back and forth while they stare at a target that's fixed or sometimes moving to kind of up the ante a little bit. They work with people on habituation, on balance and gait training, and then also endurance through walking exercises, all trying to help people feel better from their dizziness. And in general, when you're thinking of who can benefit from this, let's think about gaze stabilization for a minute. The point here is we're training the VOR. We're helping people usually who've had a unilateral loss of function and they perhaps are not compensated. And we want to help them get to that state where the central nervous system now looks down at the vestibular system and thinks that the 2 vestibular nuclei are firing a little more evenly. That's that mystery of life process called compensation, and we can help that along by doing exercises. They have a fabulous table in here where they talk about how you can tell if someone is compensated or not, and that's often something that we need to ask ourselves when we decide, should I send the person to physical therapy or not, including things like the symptom of I'm not compensated if I turn my head quickly and my eyes just cannot keep up with my head no matter what I try. So there's blurred vision with motion. People are having motion-provoked dizziness or still kind of posturally unstable. And they point out some of the tests that you can also do on vestibular testing to see some of that. The people who respond best are going to be, for example, the acute unilateral hypofunctions or chronic unilateral hypofunction. They have a ways to go. Even bilateral hypofunctions can learn some substitution exercises with them. But people who can't are usually people where the brain does not have a target to be working against. So vestibular therapy is really for people with static or kind of just like constant lesions, whereas a person with a dynamically changing lesion, not so good. So a good take-home point is, let's take Meniere's disease, for example. People who are actively having Meniere's episodes do not need vestibular therapy at that moment to stop having episodes. But once they're in a pause, oftentimes they have been left with a loss of vestibular function and feel off balance and don't feel very well in between those spells. They can then really benefit from vestibular therapy. I think it's a detriment to them if we don't offer it to try to get rid of that lingering imbalance that persists. So I commend this article to you. They'll talk about some other reasons not to do it, like mainly if people are having just spontaneous episodes and feel well in between or there's no sign of lack of compensation. And then for fall risk, I don't think that's something that I have worked into my daily exam, like on patients. I ask them about things and I try to make sure that they're not falling, and often then say, hey, talk to vestibular therapy about it. But they teach us a little more about how to do a timed up and go, a 30-second stand test, 4-stage valence test. These are great tools, and there's some nice references listed where you can see the test form and how it's administered. And if you want to incorporate that, or if you want someone in your office to incorporate that to try to reduce the risk to our patients.
Thank you. That's really great. Maya, you mentioned barometric pressure changes as something that our migraineurs notice is often a trigger. Like a lot of my patients say, I'm like that old lady down the block whose knee told her it was going to rain tomorrow, except it's my ears. So many of our patients seem to feel worse with big barometric pressure changes, or when it's allergy season, or even reaction to certain foods. So can you talk about a possible interface, Maya, between allergy and the immune system and vestibular symptoms, and how is this properly assessed?
Yeah, so it's one of those, it's not a big black box. There's certainly some things we know and some things we don't. But one of the things to sort of think about, and Dr. Dearberry is really one of the pioneers in immunologic sort of interfaces with vestibular disorders, who is the chief author for this chapter. One of the things to think about is that our endolymphatic sac has histamine receptors, and so antihistamine drugs will work on this, but you have to remember that they have to be first-generation antihistamines, the ones that make you drowsy. That's why meclizine can work for acute Meniere's disease attacks. And so your sort of second-generation antihistamines, which are more popular for allergy symptoms, are actually not going to work for these kinds of disorders. Other medications that can work would be steroids, and this is well known and well established, either intratympanic steroids or oral steroids. And then leukotriene inhibitors is a big one for allergies. And then, of course, immunotherapy where that's available. So I do definitely inquire about patients' allergies, and especially if there's a seasonality to their symptoms. And sometimes it's hard because it's really a specific season has a lot of barometric pressure changes, or a specific season has specific allergens. So it's not always easy to distinguish, is it one or the other that's acting as a trigger, and both of those could be at once. So what I like about, again, some of their sort of summaries, and they're nicely summarized in the boxes in this chapter, is the box talks about when you should do allergy testing. And so it tells you about patients who have bilateral symptoms, strong family history of childhood allergies, etc. So if you're thinking about when should I send a patient to an allergist, then that will be sort of a good starting point. When we talk about Meniere's disease, we have to sort of distinguish that with autoimmune ear disease, and it's nicely done in this chapter. Autoimmune ear disease is more typically bilateral, and whereas Meniere disease is unilateral but can also be bilateral as well. And so they give sort of a summary of when you should more think about an autoimmune ear disease versus Meniere's disease. And then finally, the last box that is in their chapter that's nicely sort of summarizing the therapeutics. These are therapeutics that are alternatives to steroids. There's certainly chemotherapies such as methotrexate. There's biologic such as TNF-alpha blockers. And then there's beta-histine and diuretics, which have been recommended for these types of fluctuating hearing losses and vertigo. I do like that Dr. Dearberry and associates sort of delve into the antivirals. Famciclovir is one that I have actually used with decent success with patients, and there's okay data for that as well. And then there's a brief sort of mention of some of the homeopathic and alternatives. We have to be careful not to recommend anything that we don't know if it works, and if we don't know, we have to make sure that there's no serious side effects. But some of the things that have been used are listed in this chapter as well.
Thank you. Yeah, and I think a lot of our patients are asking about it. You know, I think people come with some degree of education, and I think I really like this issue. I have to tell you guys, this was really a beautifully put together issue, because I think it is really patient-centric and helps us do our best to answer the patient's concerns. And I think that's really important. And for us not to poo-poo, let's say, an alternative regimen, but to say, you know what, there's not enough data, but this particular thing does not seem to be very dangerous, right? So this seems to be pretty okay to try, but there's not enough data for me to tell you it's going to work. And I think that's very helpful for people. So let's conclude our little journey through the dizzy patient issue of Otolaryngologic Clinics of North America with you, Meredith. What do you see in the future? What's in the crystal ball?
I love it. We've covered many challenges, in managing vestibular disorders, but we do want to end by saying that the future is bright. It's essential some of that is because there are people coming from so many different fields to tackle this problem of dizziness. I mean, this is becoming multidisciplinary, and we'd be remiss without saying that that's how this edition came together. I mean, it was really exciting to see so many experts in different fields be willing to contribute to this of their own time. And Maya and I want to thank all of the authors of these chapters for volunteering to do this, to dive in and just produce outstanding work. We ended the edition with a chapter by Dr. Shu and Ward, and they highlighted some things that I'm excited about, and I know all of us are. One thing we're seeing is that experts are coming together just to define these vestibular disorders. Frankly, we have not had a common language, and we see patients getting, like, who hasn't seen someone get a diagnosis of Meniere's disease that they just can't shake, and you know that's not what they had. I mean, now at least there's some criteria to go back to. It'll help scientists talk to each other, hopefully help patients get the right treatments for the right disorder. COVID has forced on us some innovation, and we're seeing telemedicine brought to dizziness. This is actually a great way to improve accessibility to patients who are suffering and cannot travel a long distance to see someone. Dizziness is made for telemedicine because so much of it is in the history. But we're seeing people really put cell phones into action. You can help someone diagnose their spell by, videotaping their eye movements. And I think we're going to see commercialization of that and actually algorithms being used to help people monitor spells and make diagnosis. And for testing, I think on the horizon, we'll start seeing that we may ultimately get that vestibulogram, just like an audiogram, perhaps, with vestibular perceptual testing. People are working on just basically contraptions. You can put a person in and they move different directions and they say if they sense it or not. Finally, something that might correlate with symptoms rather than the VNG, which is just telling me something about function. And on the imaging front, I think we're getting some exciting developments. Flat panel CTs letting us see the inner ear bone structure in a way to really get to the bottom of these unusual third windows. And we're seeing for Meniere's disease, like with MRI, we found that the perilymph takes up gadolinium kind of in a delayed manner after you administer it. You can take advantage of that to look for expansion of that endolymphatic space that suggests that endolymphatic hydrops is present. And so far, we can see that a lot of hydrops correlates with sensorineural hearing loss with Meniere's. I think we'll see that continuing to be developed, maybe get to kind of more widespread clinical use to help sort out what's going on in the inner ear with imaging. But we'd be remiss if we didn't talk about kind of the big thing on the horizon, right, the vestibular implant. Multiple groups working now to directly stimulate electrically the vestibular system, and this is in human clinical trials. I think people listening to this podcast, they probably already know that dizziness is cool, but I think once this hits, prime time, everybody's going to want to see dizzy patients, right? Finally, it's just like a cochlear implant. It's going to be, a desirable population. I hope that actually stimulates even more work and more clinical care for these patients who really need it.
I knew we were cool all along. We just didn't look or act it, but I knew we were cool all along. I'm Sujana Chandrasekhar. I'm consulting editor for Otolaryngologic Clinics of North America, and I have been speaking with two very cool cats, the guest editors of the October 2021 issue of Clinics on the dizzy patient, Drs. Maya Sracek and Meredith E. Adams. Dr. Sracek is Associate Professor in the Department of Otolaryngology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in the Northwell Health System in New Hyde Park on Long Island in New York. And Dr. Adams is Associate Professor in the Department of Otolaryngology Head and Neck Surgery at the University of Minnesota in Minneapolis, Minnesota. As I've said, all issues and podcasts are available at www.oto.theclinics.com. We would love your feedback. We'd like to make the podcast even better than they are, although how they can top this, I don't know. Thank you so much, Maya and Meredith, for putting together a terrific issue and for spending this time with me today.
This was lovely. I hope we can do it again.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on childhood hearing loss, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast on Apple Podcasts and Google Play.